Episode of Spark. You Here with you today. We have myself, Marshall McDermott, head of product at Lumiata, data scientist. Um, um, we also have Cliff Eddings here, who's a senior data solutions engineer. And we're going to be talking today about our payment integrity solution and be talking about kind of the industry and the market as it relates to payment integrity programs, what it means, why it should be important to you, and we're going to kind of go into some of our own subject matter expertise that we've developed over the years. What it is that the industry is kind of dealing with in regards to claims and payment integrity, and talk a little bit about what it is that artificial intelligence can offer you that might be additional and incremental to your current payment integrity program. And so we'll get started. And the first thing that I'd like to talk about related to payment integrity is really why it's important. In today's healthcare industry, we have multiple places of service, and each one of them has a different way that things are paid. And with that, there's a lot of opportunity for fraud, waste, and abuse. And that's typically what we think about when we talk about payment integrity programs. More often kind of around the waste and abuse side, but there are times where also fraud comes into play. And, the industry has a lot of very heuristic approaches to how these things are identified. And it's worked well for many years. However, there's things that slip through the cracks. And, we're here proving that artificial intelligence is actually a very strong way to highlight and kind of bubble to the surface those things that are being missed by traditional payment integrity programs. So how can artificial intelligence and machine learning change the payment game? One thing that I'd like to talk about is medically unlikely edits. These are typically hard-coded heuristics and traditional statistics within the industry, where actually you can highlight when someone's been given too much of something in the healthcare space, whether that's a drug or whether that's a certain procedure. And so what I'm going to do is kind of turn it over to Cliff. And Cliff, if you would, could you tell us a little bit about your experience with medically unlikely edits, and why is it important to payment integrity programs, and what can artificial intelligence do?
Sure. So the experience I have with the medical unlikely edits has been working with nurse auditors in developing solutions to improve their finding rates and also the time it takes them to audit a claim. One of the big areas we looked into was using excludes one rules with the ICD-10 codes. Excludes ones they're defined as they're mutually exclusive. They're pure excludes, meaning the one code, a certain code cannot go with another one. An example of that is the J96 family of codes, the respiratory failure. Within the excludes one codes for that family is R09.2, which is respiratory arrest. Those two sets of codes cannot be coded together. However, when we were digging through claims and doing some data mining, we found instances on claims where these codes were coded together, and by removing one of them, it dropped the severity of the claim, and also along with that, the paid amount by several $1,000s. So that's one instance where a medical unlikely edit can be an issue. Also, you have instances where it's not necessarily a written down rule, but the auditors have expressed to me that they saw issues where chronic and acute codes were coded coded wrong, where they got them backwards. They coded an acute for a chronic or a chronic for an acute, and this affected the costing of the claim. You also have codes where they're based on time periods, and if the time period is not correct, you have the wrong code and it could affect the price. An example of that would be the procedure code for a medical ventilator. You have 3 different time ranges. You have less than 24 hours, 24 to 96 hours, and greater than 96 hours. Obviously, the longer a respiratory ventilator is hooked up, the higher the cost. So making sure you have that code correct is going to affect your cost. And then also, you have different rules in the ICD-10. I'm speaking about ICD-10. You have different rules in the ICD-10 that affect only newborns. You have pediatric codes. You have codes only meant for adults. You have maternity codes and senior codes. So there's a lot of rules and different rule systems for the different coding systems that are out there, and they all affect the costing of the claim when they're not applied correctly.
Interesting. Thanks for talking about that. So it seems like what you're describing are things that are kind of medically unlikely to occur within different settings in the healthcare industry. Can you talk a little bit about the integration of patient-specific information, such as doctor's notes and medical history, and how that can play into machine learning and AI?
Yeah, so the doctor's notes and the notes in the medical claim files were where the nurse auditors went to get their information to verify a claim was coded correctly. A lot of the research that is being done in that area of the doctor's notes, the lab notes, the discharge notes, a lot of the research is finding a wealth of information that is able to be pulled from those notes. Most of the research in machine learning with medical claims has been done on the structured data, meaning the coding, finding the patterns within the codes. But the studies that have looked into the medical notes are finding a lot of more information and a lot more accuracy when applied. There's a study by Oxford in 2016 that found that whenever medical notes were applied to a machine learning model, it increased the accuracy of disease prediction, blood culture identification by statistically significant increase of 7 to 12%. And then also you have studies where the authors reviewed clinical information extraction using the codes and also applying the EHR data from the notes, and they will show there was a significant gap in the amount of information that was able to pull. But this area has not been studied extensively because you have a lot of this is covered under HIPAA, and so it's private information, so it's hard to get a lot of that data, and the data has value. So it's a lot harder to do large studies with large amounts of data in this area.
Gotcha. So are you saying that it's possible that there are actually codes that exist within the doctor's notes that don't make it to claims and that could actually change reimbursement rates?
Yes.
Interesting.
That's something auditors were finding whenever they would review claims. They would find codes that weren't supposed to be there, or codes that were in the notes but weren't in the coding system for the claim, which affects the grouping of the claim, which in turn affects the price. Cost.
So you said which affects the price and the grouping. So that makes me think that it sounds like there's some complexities kind of around anticipating and estimating what a claim will cost. Can you talk about that a little bit?
Yes. So within the medical field, you have different claims. You have inpatient claims and outpatient claims. And within that, you have different, like I said before, coding systems and different ways a claim is grouped for pricing. One of the instances one of the big instances of this in the medical field is you have Medicare, which uses MSDRG as the grouping for their claims, compared to commercial, which uses APRDRG. The two are very different. They use a lot of the same codes, but the methodology of how they are grouped is different. Also within that, you have APDRG, and within outpatient claims, they utilize CPT and HCPC codes for the groupings and don't really rely on the ICD-10 codes and diagnosis codes. And so within all that makes it difficult for the costing because you have to bring in all those different rule bases for those coding systems. But also you have different payment methodologies by location. For example, different states have different versionings and different costings for Medicaid. For example, New York, from what I've been able to look up and can tell, is still on version APR DRG 34 for Medicaid, whereas Florida is on version 38, which is the latest version. And so you're going to have different groupings on those versionings, but you're also going to have different costings on those versionings by the way they calculate the coefficient to multiply for the costing of the claim.
So it sounds like there's a large number of permutations at play with how a claim could actually be calculated for reimbursement. That goes into state regulation, commercial, non-commercial, and so it seems like that would necessitate being able to really know the industry well and know how the claims are paid within your space. Do you think that that's something that with enough data and using a neural network that you can start to almost overcome all of those complexities and predict fairly precisely without having to know all of those rules necessarily?
I mean, if with the right amount of data, you can do a lot of things. So, but it's not just the right amount of data. With all the data that you're talking about bringing in to be able to run it through not necessarily just a neural network, but a machine learning model, you're talking about compute power, you're talking about storage. I mean, there's a lot of other factors to consider on that. And so the scope, the enormous scope that you're talking about doing, is it possible? Yes. But is it feasible? Probably not.
Gotcha.
And then you also go back to a lot of this information and data is privacy protected under HIPAA. So getting access to that is very, in large quantities, is very difficult.
Gotcha. So I guess outside of value-based care, where the claims are paid with these payment structures, I think in the costing that we talked about, can you go a little bit deeper into those difficulties and talk a little bit about the different payment methods that exist? I know you mentioned MS and you mentioned APR DRG. Could you talk about those, and are there any others?
Okay, so APR DRG and MSDRG are for outpatient, inpatient prospective payment system, which they consider location, access, and diagnostic factors. You also have fee for service, which is line item payments. A lot of that is done by outpatient line by line charges. Whereas the outpatient inpatient looks at location and access, fee for service rewards the volume of care based on line by line. And then you also have different non-traditional settings, I guess you could call it, skilled nursing facilities, outpatient hospitals, psychiatric hospitals, ambulatory, telehealth. Nowadays, that's a big one now. Pharmacy, home health, all those are different, have different aspects of their payment system also. So you have more than 15 active payment methods, and with 20 plus different payment calculations across different places of service. And the levels of use are different, as we've shown by state also.
Right. So if you were going to do this with a fully blown payment integrity program in-house, it's a pretty large undertaking with that many different payment methodologies and different considerations. So we've talked a lot about the kind of the health plan, the payer side of things, and the claims. One thing that I don't know if it gets enough time in the sun is really what the provider experience and what the kind of perceived payment differences and nuances are within the provider network world. And we have Barbara here. Barbara has experience working with provider billing systems. Barbara, could you talk to us a little bit about that and give us some of your background and insight?
With providers, it's all about how do you get your first best shot. And that comes back to this problem that we have in the American healthcare system where providers spend a lot of time on administrative tasks like how do I bill for my patient that I just treated in the ER and I'm exhausted and I have 10 more patients to treat, when they should really be focusing on what their specialty is, which is delivering care and treating patients. And so how I see AI fitting into this is that you can reduce the amount, you can reduce the amount of time spent on billing tasks and administrative tasks, which it has been estimated by various consulting firms to take up, around 15 to 20% of a provider's time throughout their day. And that can really be helped by artificial intelligence who can mimic a billing expert in a way by mining through past claims and through what in the tech industry has really proliferated through these recommendation systems. Once you have treated a patient, what are the best billing codes to submit to a payer for it to be reimbursed the quickest without and reducing the amount of the adjudication process.
Gotcha. So let's say that I'm actually about to submit a claim and it might not be the most accurate or maybe doesn't have the greatest reimbursement opportunity. How do you actually fix a claim?
Right. So that can, mean different things depending on what the error is. I think that typos are easy to catch for humans, but what an AI can really help with is how do we pair the right amount of codes to bill with the payer that we're submitting to? For example, something that has a new type of billing that has come up during the pandemic especially is telemedicine visits. And different payers have different, strategies for billing telemedicine. You could use either a G code, which is new, I believe, in 2021 for telemedicine, if I'm not wrong, or you could use an E&M code, which has classically been used to bill for these outpatient medical visits with a procedure modifier that indicates that it's a telemedicine visit. And that which strategy to use, it really depends on the payer that you're dealing with. And for large healthcare systems, they may already have this set up with people specializing in a billing department that specializes in how do we transform these doctor notes into claims to submit to payers. But for smaller practices, they may not have the resources, and it would be really great to have this process automated by artificial intelligence so that you can be right the first time and not have to go back and you may have submitted an E&M code with a procedure modifier to a payer that really wants you to see a G code. Like that could really be fixed in the beginning before you submit.
makes sense. Thank you for answering that question I had. So I guess right now it kind of makes sense to talk a little bit about Lumiata's payment integrity solution. We've talked about some of the difficulties in the space and covered a little bit on both sides of health plans and providers. One thing that we at Lumiata with our payment integrity solution have really focused on is how do we use artificial intelligence and deep learning to learn the things that the current practices and programs are not finding, things that heuristics and statistical methods are not identifying. We gave MUE examples earlier. A lot of those MUEs are published lists from CMS where units are not allowed to exceed a certain number, or where two codes can't exist at the same time. And what artificial intelligence and our solution has the capability of doing is really learning the items that are not on that list that can't occur at the same time. Things that are just completely unfeasible, such as someone having a prosthetic knee replaced at the same time that they're having a musculoskeletal knee replaced, because it has to be one or the other. It can't be both on the same knee. One thing that we've seen be highlighted is there's a specific cancer therapy where a syringe might contain 47 milliliters of the therapy drug, and in other settings it's tracked by just one unit as a syringe. You'd be surprised how many heuristic and statistical approaches actually miss those things, and it can amount to the magnitude of tens of thousands of dollars that it's costing these health plans, and just waste and kind of abuse in some cases within the system. And another thing that we focus on is really the identification of anomalies. So the thought is that there is kind of a standard best practice way to care for patients that have specific diseases, and anytime that we see something that is completely anomalous to what the data has shown in the past, that's something that we want to highlight, because we want to audit and make sure that did someone have a typo? Was something coded incorrectly? And those are things that are actually very easy to integrate and implement within systems. And you can also come back behind and put the Lumiata payment integrity program on top of existing programs, and let us find additional recovery and ROI for you. So that's kind of where our artificial intelligence work with payment integrity has led us. I think the last thing that I wanted to cover is to be cognizant and kind of talk about ACOs and value-based care, because I think it's a hot topic within the industry. It's something that anyone in the healthcare industry kind of knows about, this whole holistic approach of taking care of an individual and basing reimbursement on the outcome as opposed to individual payment methods. You could see that as the eventual migration change, or really putting an end to of payment integrity programs as they exist today. However, we all know that there's kind of a slow transition process. And I think what would probably hurt the industry the most is to, during that interim period, not pay the right amount of attention to our payment integrity programs as that migration happens. And so, I think it's important to point that out and make sure that the industry knows just how important it is to engage in these types of programs, so that we're giving the healthcare dollar back to individuals who really need care. And the good news is Lumiata is ahead of the pack when it comes to value-based care as well. So it's when we eventually round that corner, we'll be there ready for that also. So that actually concludes our Spark session today. And we appreciate you taking the time to kind of view and listen to what we have to say. And if you're looking for payment integrity solutions, feel free to reach out to Lumiata. Thank you. And we hope you have a nice day.